TopMedTalk.
Well, hello and welcome to TopMedTalk. We're at Euroanaesthesia 2024, the annual Congress of the European Society of Anaesthesiology and Intensive Care. We're here in Munich, Germany, and it is absolutely fantastic. I'm Desiree Chappell. I'm your host, and I'm delighted to be joined by Professor Kate Leslie from Australia. Kate, thank you so much for co-hosting with me this weekend.
Oh, it's going to be so much fun, Desiree.
Well, after your performance, I will say, down and at ANSCA, the annual scientific meeting for the Australia-New Zealand College of Anaesthetists, you did TopMedTalk Down Under. It was fantastic.
It was really fun. Andy Cumsty and I did 17 interviews.
Was it 17?
It was.
17. Oh, my God.
And we would have done more.
Did me proud. I love it. I love it. Well, they're fantastic. If you haven't had a chance to listen to them, I would please go check them out on TopMedTalk.com. They are absolutely wonderful. So thank you for all your hard work. Well, we wanted to give a big shout out and thank you to the ESAIC for supporting TopMedTalk to be here in the exhibit hall. This is our first time at the meeting working directly with the ESAIC. They gave us this nice little space here in the back of the exhibit hall where we can kind of watch everybody go by and get some great conversations going. So we wanted to thank you so much. And thank you to all of our sponsors who make TopMedTalk free and open access to the world. So we always want to give them a plug. Now, Kate, I'm really excited about this conversation. We were going to save it for a little bit later, but we thought, let's just do it here while we're at the ESA or at Euroanaesthesia. Our next guest is a fan fave for TopMedTalk. We've had a great conversation, but it's been a while. So Liz Everett, thank you for coming back to TopMedTalk and chatting with us.
Thanks, Desiree, and thanks, Kate, for having me. I'm really looking forward to having a chat.
Yeah, the last time that we sat down with you, it was back in 2019 in Prato, Italy, for the collaborative clinical trials meeting, correct?
Yes, that's right. Yep. Yeah, it's hard to imagine that was 5 years ago.
At BC, before COVID. Why don't you tell us a little bit more about yourself for those who may not have heard that previous conversation?
So I'm a neuroscientist in anaesthesiology. I'm currently an associate professor for neuroscience in anaesthesiology at Weill Cornell Medicine. And I still hold my appointments in Melbourne at the Department of Critical Care, University of Melbourne, and at St Vincent's Hospital. Predominantly, my research is looking at perioperative neurocognitive disorders and looking at strategies to try to prevent or reduce the severity of those disorders.
We haven't had as much conversation on TopMedTalk about delirium and post-op cognitive dysfunction, so I think that's great.
I think, I'm delighted to be doing this. I think it's so important. It's the most common complication of surgery and anaesthesia for patients 65 years or more.
Yeah.
Increasingly, we are seeing that there are long-term complications for patients, and not just in terms of cognitive function and the physical function, but also in terms of depression, refusing further treatment because the negative sequelae of the experience. So It's a really important area.
Yeah. And you said Cornell, so that's the U.S. and Australia, so you're splitting your time.
I'm predominantly based in New York, but I still have my team in Melbourne, so there's a lot of Zoom calls at odd hours.
That's right. Well, Kate, you have invited another guest to the show. Why don't you introduce him?
David Scott is an anaesthetist and researcher from Melbourne, and I'll get him to tell us a bit about himself. Thanks, David.
Well, thanks very much, Kate, and thanks, Desiree, for inviting me along to this conversation as well. So, yes, I'm based in Melbourne. I'm a clinical and academic anaesthesiologist based at St Vincent's Hospital in Melbourne, and I'm a professor at the University of Melbourne in the Department of Critical Care. And my research focuses on patient outcomes over the years. For the last over 10, maybe almost 20 years now, we've been looking at, as a group, cognitive outcomes from anaesthesia and surgery, particularly affecting the elderly patients. We started off hearing all these stories about grandma was never the same after she came into hospital. Something must have happened in hospital. Why is she different? And it's consistent. This continues to happen. And also people themselves spontaneously say, look, I feel this brain fog after my surgery. I'm not quite the same. And sometimes suddenly got better. Sometimes it just never cleared properly. So we really have been exploring that and trying to find out how we can match the clinical outcomes that we see with some form of mechanism and some form of understanding of what that might become. We moved into an alliance with the Alzheimer's Association International. This was the founding chair of the professional interest area in that group, which was looking at delirium and perioperative neurocognitive disorders. And that brought a whole new world to us as researchers, and we've got a whole lot of engagements with researchers in basic sciences across America and Europe and Australia and the UK just to explore these areas, which is fascinating because some people have got rats running around in a maze and some people have got patients in rehabilitation wards. And it was great to be able to try and link all these things together.
And there was a big piece of work that you were both involved with, and in fact Liz substantially led, where you drew together geriatricians and perioperative researchers and basic scientists to come up with some common language. Liz, do you want to recap that? That was very important work.
Yeah, thanks, Kate. So the recommendations for the nomenclature of perioperative neurocognitive disorders is something we started on actually 10 years ago now. We put together a group of experts from the multidisciplinary fields of medicine that actually are involved with caring for these patients. And so we, rather than having this isolation of what's happening in the perioperative period, we really felt we needed to talk about these cognitive disorders in terms of what's happening in the overall trajectory of an older person. So patients who go to a geriatrician or a psychiatrist to have, with a memory concern, to have some sort of assessment and diagnosis are the same people who are coming to hospital to have surgery and anaesthesia. So we felt it was really important for us to address what's happening in the perioperative period in the same way and consistently with what's happening in the community. And so we had a group of 40 geriatricians, psychiatrists, neurologists, neuropsychiatrists, anaesthesiologists, and we put together a recommendation for definitions and criteria for the cognitive impairment that we see in the perioperative period, but how that contextualizes within the holistic pathway of an older person. So rather than looking at it as something completely separate to a person's life, we're trying to bring together what's happening in the community with what's happening in the hospital.
It really changed a lot of the way that these sort of trials were reported in a really good way, didn't it, David?
Look, it did, Kate. And to build on what Liz said, the problem that was identified early on was this thing called POCD, perioperative cognitive dysfunction. And that was simply a research tool. It was applying a whole lot of neuropsychological tests to patients over a period of time after anaesthesia and surgery. It didn't relate to a clinical outcome necessarily. And what the nomenclature does, which Liz described, is it links clinical to research in that way. So now you're combining functional outcomes with measured outcomes, which you can measure objectively with neuropsychological tests.
Yeah. You're also doing quite a lot of work with biomarkers, which goes to the more basic sort of mechanistic element of it. Can you tell us a bit of your recent research in that area?
Sure. Biomarkers are a fascinating area. Obviously, I want to focus on body fluid biomarkers, so CSF or blood. Our lab colleagues sort of had identified, particularly associated with the Alzheimer's group, that animals exposed to anaesthesia and surgery did express more A-beta, tau changes, which were consistent with some of the pathological processes associated with amyloid-related Alzheimer's disease. And so there was a clue that perhaps these could be measured and related to a perioperative neurocognitive disorders as well. And the jigsaw puzzle is still being put together. I guess with biomarkers, what we want is to be in the same position as we are now with myocardial disorders. So you can measure someone's baseline myocardial stress with BNP, for instance, or you can measure an acute event with some form of high-sensitivity component. We would like to be able to do that with biomarkers for perioperative neurocognitive disorders. So looking at baseline, we want to see what the status of the patient is, and we can correlate that to a clinical status. And during the post-operative period, we're doing samples up to a week, sometimes longer, looking to see if we can correlate that with clinical changes like delirium.
So there must be groups of biomarkers that represent different potential mechanisms. You've mentioned ones that relate to the Alzheimer's amyloid story, but there are others that relate to apoptosis and to inflammation, aren't there?
Yeah, so you could probably simplify them down into three main groups, I suppose. There's the inflammatory biomarkers, which current evidence suggests that systemic inflammation does affect the brain, and that crosses and the blood-brain barrier becomes a bit more permeable during that inflammatory process. So inflammatory biomarkers are important as an indicator of either baseline, the patient's already got an inflammatory condition going, or subsequent to the surgery, we see that rise, and we've measured that, we've published that.
And what's an example of one of those?
Well, interleukin-6 would be the archetype of those. Tumour necrosis factor alpha would be another The whole interleukin range is 18 interleukins, but TNF, interleukin 6 seems to be sort of, if you like, the trigger factor then. And then the C-reactive protein, which is a slower to rise inflammatory biomarker, which we all understand and we all know well. We can measure that in the lab. That's a routine lab measurement. It's a bit more non-specific, but nonetheless it's a downstream effect from the wind-up of inflammation.
And then there was another group of...
So the next group I briefly mentioned the amyloid biomarkers. They're probably an indicator more of chronic cognitive impairment. So we have associated higher levels of, relevant levels of amyloid biomarkers depending where you measure them. So paradoxically in CSF, if you measure amyloid beta 42, it lowers when you've got Alzheimer's disease because it's being aggregated around the neurons. But those markers are associated with cognitive impairment, and I think that's the link there at baseline. And the final group are the neuronal injury biomarkers. The archetype of that, which we're really following closely, is neurofilament light. But there are many others as well. There are glial injury markers as well, such as GFAP and S100 beta, which many people will have heard about. But looking at neuronal injury, tau and neurofilament light are quite significant markers.
They're significant markers in traumatic brain injury, in all neurodegenerative diseases. And it's really interesting to see that they increase in the perioperative period in a way that's very similar to what happens, for example, when sports people will have concussion. So, yeah, there are interesting parallels between, a variety of different disorders where we're seeing those very similar changes in the markers of neuronal damage.
And then the clinical expression of those. I mean, what are some of the things that we're really seeing with patients when you see elevation or in some of those biomarkers?
So I guess as David said, there's two aspects to that. One is baseline. So are people who are more at risk, in an elevated state of those biomarkers in the preoperative period, and can we use them to predict those patients who are at highest risk? And then there's the issue of what happens in the perioperative period and those increases we see. And one of the difficulties with this work is that generally speaking, both the inflammatory biomarkers and the neuronal damage biomarkers peak at different times. So it's quite difficult and challenging to see the pathway. But in fact, there's good evidence that a more sustained increase or a greater level of an increase is associated with postoperative delirium.
Yeah. And so for our more general listeners, what sort of symptoms and signs will a patient be displaying when they've got high levels of these markers or we're concerned about them postoperatively?
The signs and symptoms may not be evident to the person. So if the patient
is... the doctors?
I say both ways.
Yeah, so I mean, hyperactive delirium is a very agitated state and is very obvious to to the patient themselves and to the people caring for them, and very distressing to them and their families. Yeah. Hypoactive delirium, on the other hand, is something that, really isn't obvious to anyone, even the patient themselves. They may just be quite sleepy, but they're actually not comprehending very well what's going on. So they're not going to be understanding instructions that they're being given. They won't necessarily know where they are. They might not be oriented to time. They might be feeling confused. They might be having some sort of hallucinations. And what we find oftentimes is that patients just, think that this is kind of normal and don't mention it unless we actually do an assessment. And so it is really important because it can be very distressing. Even hypoactive delirium can be quite distressing to patients. So really, the idea of identifying patients by routinely screening is really important.
Well, like you said, having the baseline before and after, and being able, having really providers who have seen them before and after too makes a huge difference, because then you kind of tell it.
Involving family.
I was just going to say that
educating patients and their families before, and using family members as people who can help with those sorts of
theorization.
Yes.
Yeah, that's right. And understanding, is this different to how the patient was preoperatively?
My father, he listens to this, so Dad, I'm not breaching any too major confidence here. Recently had a procedure, and I talked to both my father and my mom about the fact that this is a possibility and we need to really watch for that. I mean, my dad, sharp as a tack, never forgets a name ever. And do you know, and he's healthy as a horse, takes no meds, nothing at all. He's really very healthy. Brain fog. He's still 6 months later is still having a little bit of brain fog where he's like, I just can't remember that person's name. It just doesn't feel quite as sharp as he used to. And I thought for sure. And we actually, I wasn't in the procedure, but I was obviously working with my anesthesia colleagues to say, well, let's avoid opioids, let's do a block, all these different things. And we did all those things and still, he's experiencing this.
Most of the work that has been done in this field would suggest that it's not anesthetic agents that are responsible for these sorts of foggy head and
so is that more of like an inflammatory response?
Yeah. So David,
that's exactly right. So a lot of the links between anesthetic agents, when explored clinically, don't show a link to per se.
Yeah.
And it might in fact be that we will work towards anesthetic agents and the approach we do to be protective in the future. But you did all reasonable things, being alert to it, talking about it beforehand.
Yeah.
That brain fog can be really frustrating, even for younger patients. People in their 40s and 50s can describe it. Sometimes it's like a switch when it gets better, and it's like, a week later I could almost put it down to the hour or the minute and they felt better. But otherwise, it can persist, and 1 in 10 patients after most types of surgery will experience some degree of, neurocognitive impairment at 3 months if you measure it closely. And that could be subtle, but it's got a clinical effect. And that's why the nomenclature tries to tie in what psychologists and psychiatrists use in DSM-5 to classify these things. So there's actually a meaningful link to that, so we can do further research. Because the bottom line is we've got nowhere near all the answers yet. The biomarkers just are a start on the way of identifying mechanism, identifying risk. But we need to explore it more, which is why we're continuing to sort of speak from pulpits.
That's all right. Okay.
The two of you have done some fantastic research over the years, but I think the one that affected me most sort of emotionally was the recent research you did about the emotional and psychological effects that an episode of delirium can have on an old person.
Oh. Yeah.
I found that it was quite sad, really. Can you just tell us how you did that work and just what the results were?
I think it's a really important point because in general, this work has all been about yes or no post-operative delirium, maybe, which features did you have, but very objective sorts of outcomes. And so we had some work that was led by one of our honours students, actually, and
in Melbourne, Australia?
In Melbourne, Australia. She is a psychology graduate and she was interested in doing some qualitative thematic analyses. And so
Caitlin
Cohen. Thank you. Sorry. And Caitlin interviewed 30 patients who had had cardiac surgery 3 years prior and had experienced delirium, either hypoactive, hyperactive, or both for some patients. She found that, in fact, 3 years later, those patients were experiencing a lot of symptoms of depression and they were really quite traumatized. And, from their perspective, that was the result of the period of delirium. Many were sort of having quite a lot of anxiety about how they had, people who had hyperactive delirium were quite distressed by pulling their lines out and things. And in particular, that nobody had named it for them. And so they didn't understand that it was not within their control. So for some of the patients, they felt that there was something they did that caused that. And so even 3 years later, they were experiencing some serious consequences and in some cases refusing further medical treatment.
They were embarrassed by it. They were traumatized.
Yes. I was just going to say trauma. We've been talking a lot about trauma.
Absolutely. It's a form of trauma-informed care. But the prevention, well, not prevention, but help is, as Liz said, to identify it, to recognise with them and their family that they're not out of their minds. This is not something we want to happen, but we know it does happen. And, we provide it with encouragement, although we do know professionally that having episodes of delirium is either a sign that they've got some degree of cognitive risk or that delirium itself causes some neurocognitive injury. We're still not sure on that. Is it both or is it either? But we do reassure them that, most, by and large, they will recover to, where you would expect them to be. And without that reassurance, they're blind.
Absolutely.
Yeah.
Well, I think it would be so terrible too, 3 years post-surgery, you're having depression and anxiety. And you know that this was a traumatic event, but maybe friends don't know. So you can't name it. You may not be 100% of that's the cause, but it's a lot to struggle with, even 3 years later.
And you don't want to discourage people from getting life-enhancing surgical interventions. This is important. The message is we'll do our best to help you.
Yeah.
You may have a difficult time, you may not.
Yeah.
But we recognise it and we're working on it as well. From a research point of view, yes, we're working on it, we're getting better.
Yeah.
But at the moment, it's clinical interventions. It's multifactorial, multi-component interventions, which is probably where you're going to head, is how can you prevent this?
I guess we'd like to ask both of you, briefly, what's next in your research world? Lynn, take it away.
So I'll talk about non-pharmacological interventions.
Great.
David can cover the other sorts of strategies. But I think the most exciting sort of area at the moment is looking at non-pharmacological interventions. So we know that Sharon Inouye's HELP guidelines can be implemented when patients are, during their admission post-surgery. And they're things like making sure the patients are mobilised, making sure they have their hearing aids and their glasses, their teeth, making sure they're eating and drinking as quickly as they can post-operatively. So I think, there's kind of 3 phases of non-pharmacological interventions which cover preoperative optimisation. So let's get our patient into the best possible state they can be preoperatively, even if that means maybe delaying the surgery for a little while.
And how do you do that cognitively?
So cognitive stimulation has been shown, even on its own, to reduce the risk of delirium.
We should get them all on TopMedTalk.
Oh, there you go.
That's cognitively stimulated.
But things like, polypharmacy, reducing the number of medications, exercise, getting patients as fit as they can be, nutrition, just trying to get them into the best possible state, controlling cardiovascular risk factors as well as possible. And then during the admission, in the perioperative phase, doing as much as we can intraoperatively. As I said, not a lot of evidence that what we can do intraoperatively is going to make a difference. Then on the ward, as I said, the HELP guidelines, get the patients eating, drinking and moving. And then post-discharge, education about maintaining those sort of, improvements in lifestyle risk factors. All cardiovascular risk factors are risk factors for cognitive disorders. So let's stay in the best nutritional health, physical health, and cognitive stimulus is good. Use it or lose it.
Yeah.
Is true for cognition as well.
So I want to make sure, what are they?
Hospital Elder Life Program. So the American Geriatrics Society website has a host of resources about delirium, including the types of delirium assessments that can be done, even training videos for researchers who are interested in doing that. So the American Geriatric Society website is a great place for resources for delirium.
That's great. We'll signpost in our show notes people to that. I think that's really important.
And David, what about you?
I think Liz has outlined how complex it is to manage and how to prevent. And the Hospital Elder Life Program guidelines also refer to hospitalised patients who are medical, for instance. So we've got to not forget those. In fact, they are probably the larger proportion of risk associated with delirium, which, as I'm sure you will be aware of if you have older family members who have been involved. There are 2 sides, I guess. One is identifying risk better and more easily, and we're nowhere near that with biomarkers yet, but, properly screening patients beforehand and making sure we can put them into a pathway of protection is ideal. What excites me is the possibility of protecting the brain during its peak area of risk, and that would be... We might be able to optimise anaesthesia. There are drugs which show promise, like dexmedetomidine, which may be useful intraoperatively as well as we know it does help postoperatively in ICU. There's no drug which can switch off delirium at the moment. It's a complex neurocognitive electrophysiological challenge to the brain, and we're not quite there yet with stabilising the brain to reset it, if you like. I'd like to see that occur better, and that will come with us understanding the mechanisms better. And there's been a lot of talk at this meeting about EEG monitoring and improving the way we as anaesthesiologists do that. But, on the post-operative ward, as well as taking blood pressures and oxygen saturation, it may well be that we use some form of EEG monitoring and enable us, one, to identify those at risk with non-pharmacological interventions, but also maybe some other protective interventions which we will better discover down the track.
That sounds fantastic.
Lung protective ventilation. We have brain protective anesthesia. There we go.
Yep.
I'm up for it.
All right, let's do it. Thank you guys so much for sitting down with us on TopMedTalk. This is a fascinating topic. I know I had probably about 10 more questions and rabbit holes we could have gone down. Hopefully we can catch up again as the research continues to grow in this space. So thank you guys so much.
Thank you so much.
Yeah, thank you very much.
Absolutely.
Great talking.
And thanks for listening to TopMedTalk. Kate, thank you for hanging out with me. I didn't say that.
It's a pleasure, Desiree.
It is. And thanks for listening to TopMedTalk. You know, you can find us on your favorite podcatcher. We're on YouTube now. If you found us on YouTube, give us a thumbs up, subscribe to our YouTube channel. Every little bit helps. And if you liked what you heard today, share with some friends. There's some good content, especially around brain health and brain protective anesthesia. Check that out on TopMedTalk. Cheers, everybody.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.